everyone. Welcome to the next session titled Key Considerations for Integrating Fentanyl Education and Naloxone Training into Schools. I wanted to give you a little context on this one because remember how we've been talking about throughout the day these hard questions that keep coming up throughout every system, whether it's at the individual level, organizational level, community level, family level. This is one of those hard questions that has come up, and it's come in through multiple TA requests, particularly from states and schools. Specific to legislation has now been passed within my state and my school district to integrate or at least offer some type of fentanyl education, possibly naloxone training combined with that, to our middle and high schools. I'm not quite sure how to think through that. I'm not quite sure how to integrate it appropriately into the current prevention programming that we have going on at this time. And then from state levels, it's what are some of the best practices for this? What can we be recommending to the school districts out there? So what ADAPT did was, we don't have all the answers, obviously, and we reached out to some of the experts who have been swimming in these types of questions and have experience with at least some dimension of this in the past. And we put together a task force chaired by Dr. Robert Lachos. And we asked them to create a starting point for helping us think through this. And boy, was it more than a starting point. What they actually gave us was something really beautiful and very full in its entirety of really how to start thinking through it, not just from a content standpoint, but from this big, beautiful picture of prevention within a school system. So you all have access to this new resource that is being put in the chat box under our Prevention Intervention Resource Center. It is the one on preventing opioid use in youth, and it is our resource based on the best available evidence out there at this time. And so with that, I'd like to turn it over to Dr. Lachos. Bring this baby to life, Dr. Lachos. Thank you for putting this panel together.
Thanks, Laura. I really appreciate it.
Hello, my name is Jim Mitchell. I'm the demand.
So we're hoping that by the end of today's session that you all will be able to identify opportunities for schools and community partners to work together to address fentanyl and opioid use. And we're going to discuss positive prevention strategies that we think as a task force that should be addressed in school-based settings. I want to recognize the members of the work group. This represents the best researchers, the best school-based folks, the best health education folks in the nation that could address school-based opioid fentanyl prevention and intervention in the United States. As Laura had mentioned, there will be a document coming out that is the outcome of work that's been done over the past several months of the task force that addresses how to best approach preventing opioid use in schools. And this report has a number of important sections, including an introduction that looks at the epidemiology, looks at how to approach both primary, secondary, and tertiary prevention, looks at what works and what doesn't work in primary prevention, specific recommended approaches and curriculums that could be used in schools, guidance in terms of implementing these approaches, and then we conclude with secondary and tertiary prevention approaches, particularly addressing very, very important harm reduction strategies that schools and community members need to consider if they're going to prevent opioid and fentanyl overdose in their community. And then we conclude with some of the main points and findings and recommendations that we would encourage folks thinking about preventing opioid and fentanyl overdose and use in the United States consider as they begin to approach reducing overdoses among youth.
Thank you, Dr. Lachos. We actually, my mistake, we forgot to introduce all of you wonderful folks. So we're going to do that right now as we transition over into you diving a little deeper into that tool.
Hello, my name is Jim Mitchell. I'm the demand reduction coordinator at the Oregon-Idaho HIDA. The prevention goal here at the Oregon-Idaho HIDA is to support evidence-based prevention efforts in the Oregon-Idaho HIDA region to reduce youth substance use. We have 4 objectives identified to facilitate the accomplishment of this goal. Number 1 is to understand drug prevention needs across the Oregon-Idaho region. Number 2 is to establish and maintain partnerships with key stakeholders across the Oregon-Idaho region. Number 3 is to translate drug prevention science for community partners. And number 4, invest in the best available evidence-based drug prevention interventions. Diving into primary prevention is a new endeavor for us here in the Oregon-Idaho HIDA. Over the past 7 months, we've helped reconnect prevention professionals from across the region and sharing best practices. Additionally, we are partnering with the region's prevention community and ADAPT to host Oregon's first ever primary prevention conference in the spring of 25. We are optimistic that we can help our dedicated prevention community regain support and enhance their effectiveness in building safer communities for our youth. It is my pleasure to introduce our group of panelists. Across the nation, communities are moving towards integrating fentanyl education and naloxone into schools. Many are asking how to do this within the context of a school-based prevention system. Our next panel represents several members of a task force assembled to answer this very question. Together, they will share key considerations grounded in the best available evidence for how to most effectively educate students on fentanyl and provide naloxone training in schools. Dr. Robert Lachasse will moderate this panel. Dr. Lachasse is a professor at California Baptist University and board member with the National Prevention Science Coalition. He is a nationally recognized leader in the areas of substance use prevention, program evaluation, and prevention science. He has advanced the field of prevention science through the research in the areas of alcohol, tobacco, drug prevention, teen pregnancy prevention, obesity prevention, and parent-child relationships. Our next panelist is Ms. Holly Alprin, Clinical Associate Professor at the University of New Hampshire. Ms. Alprin has over 25 years of experience working in public health and education at local, state, national, and international levels. She has dedicated herself to preparing future health and physical educators and supporting school leaders in designing and implementing effective educational interventions that improve the health and well-being of young people. A few examples of this work include school health education and whole school well-being programs, physical education and comprehensive school physical activity, and school nutrition programs. Our third panelist is Dr. Michael Hecht, President of Real Prevention and Professor Emeritus at Penn State University. Dr. Hecht started in prevention research over 40 years ago, and his work focuses on school and community-based prevention, culture and health, health message design, and narrative health messages. This work includes several evidence-based interventions that advanced his narrative engagement theory and principle of cultural grounding, such as Keeping It Real, HPV Stories, Mighty Teens, Real Media, Real Parenting, the Opioid Response System, and the Student Athlete Wellness Portal. On behalf of the Oregon-Idaho HIDA, we are grateful for our panelists joining us today to share guidance on the timely issue of fentanyl education and naloxone training in schools. Dr. Lachasse, over to you.
This opioid fentanyl overdose epidemic. And if we look at the funding in the United States, both at the federal level and at the state level, most funding to address opioid and fentanyl overdoses are allocated to treatment. In fact, for every $7 we spend on treatment, we spend $1 on primary prevention. But we know that primary prevention of alcohol, tobacco, and other drugs, including opioid and fentanyl, is more cost effective and is more likely to lead to reductions in other costs associated with overdose, including ER cost, healthcare cost, EMS cost, judicial system cost, and other costs associated with this epidemic. Fentanyl overdoses are most often accidental, but they are completely preventable. And youth opioid crisis closely aligns with counterfeit pill use. and the use of prescription opioids in an improper manner. When we look at the data regarding opioid deaths, they dramatically increased by 67% between 2017 and 2023. But towards the end of 2023, we saw a significant decrease in opioid and overdose deaths. When we look at the literature, there's not a lot of evidence to point to why there's been this decline in many states, but not all states, in opioid and fentanyl overdoses. We know that 7 in 10 opioid pills contain lethal doses of fentanyl. And we also know that there are racial and ethnic disparities in overdose rates, with American Indians, Alaska Natives, and African Americans having the highest rates of opioid and fentanyl overdose. We also know the age group between 26 and 44 have the highest rates of opioid and fentanyl overdoses. And when we look at the geography of the United States, we see that overdoses are the highest in West Virginia, New Mexico, Tennessee, Vermont, Maine, Pennsylvania, and Delaware. But I want to point out that no place in the United States has gone untouched by the opioid and fentanyl overdose epidemic. In fact, 1 in 5 Americans in a recent Kaiser Family Foundation survey said that they had been touched in some way by the opioid fentanyl overdose epidemic. One of the natural ways that we think is good to prevent opioid and fentanyl overdose is in schools, because kids spend the majority of their developmental lives in schools from about age 4 or 5 until about age 18. And schools can be a unique and appropriate opportunity for community members and educators to work together to prevent youth from participating in alcohol, tobacco, and other drug use, including using opioids and fentanyls. Adults can support the development of a school climate that promotes connection, prevention, and also a sense of well-being. And primary, secondary, and tertiary prevention efforts can be coordinated through and with school staff. Now I want to turn our attention to what works in substance use prevention education, including fentanyl and opioid prevention education. One of the main things that our work group came up with is that schools need to be implementing evidence-based interventions in their universal, what we call primary prevention programs. Evidence-based interventions are those that have been developed and tested over time and have demonstrated effectiveness in either reducing the likelihood that youth would use alcohol, tobacco, and other drugs, or reduce the frequency in which they use alcohol, tobacco, and other drugs, including overdose. So it's very, very important that schools, along with communities, identify and select evidence-based interventions rather than developing their own approaches, curriculums, or interventions. When we developed the document, we came to the conclusion that fentanyl and opioid prevention is probably no different than the prevention of other substances, including alcohol, tobacco, and marijuana, methamphetamine, and cocaine. There's no reason to believe that the determinants that would decrease the likelihood that a youth would use alcohol, tobacco, and other drugs would be any different than it would be for opioids or fentanyl. But when we look at evidence-based interventions, that is, those that have demonstrated positive outcomes, we see that a common characteristic is they decrease their emphasis on increasing awareness or increasing knowledge, and they increase the opportunities for kids to learn skills. These skills could be assertive communication, they could be refusal skills, they could be identifying, managing, or escaping a risk situation. They could be media literacy skills, or they could be advocacy skills. So we see the most effective alcohol, tobacco, and other drug prevention programs emphasize skills, and they limit any education on awareness or information building. We also see that the most effective school-based alcohol, tobacco, and other drug prevention programs have to be in sufficient dose in order for them to have any effect at all. And when we look at the literature, we typically see that it needs to be somewhere between 10 and 15 hours of instruction. And the most effective ones contain booster sessions in subsequent years. So if we start doing primary prevention, let's say in grade 6 or 7, with 15 45-minute lessons, the most effective programs have follow-up, or what we call a booster, in grades 8 and grades 10. It's also important to point out that primary prevention programs need to occur with youth prior to when they tell us that they're likely to be pressured to use alcohol, tobacco, and other drugs, which is around grade 6 or 7. We also know the most effective programs increase youth perceptions of risk and promote anti-substance use norms. When we survey kids, they often will tell us the majority of their peers are using alcohol, tobacco, and other drugs. But when we survey those same kids and we ask them how often they're using, if ever, alcohol, tobacco, and other drugs, the percent of youth is much lower than what kids often perceive. Another characteristic of effective alcohol, tobacco, and the drug prevention programs is that they're implemented with fidelity, including the use of effective and engaging delivery methods. The programs that don't work are where kids are watching something, taking notes, or taking quizzes. But when kids are up and out of their seats, they're engaging in a role play where they're actually practicing using refusal skills, assertive communication skills, or they're using skills related to identifying, escaping, or avoiding a risk situation. Those kids are much more likely to develop those skills and use them in their everyday life. Now I'm going to turn it over to Holly Alperin, who's going to talk about implementation guidance.
Thanks, Robert. When we think about implementation guidance, one of the things that we want to keep at the forefront of our minds is that prevention happens across a variety of different sectors. And that means that a variety of different individuals need to be involved, and coordination is key. This means bringing folks to the table and inviting in multiple voices. When we're integrating fentanyl and opioid education as a part of comprehensive prevention efforts, we're doing a couple different things. We're meeting young people where they're at. We're addressing the social norms and stigmas that might be present in the community. And we're also recognizing and understanding how and when and where we're trying to do different prevention efforts. So for example, prevention efforts might look different in a school setting than they do in a community-based setting, based on the time allocated with young people, or even the availability of the adults who are able to work with those young people. We want to keep in mind upstream factors, root causes, and community needs. So what do I mean by this? What we mean by this is that, as Robert had mentioned, substance use isn't just something that shows up or something that just happens. There's a variety of different factors. And I know that throughout the day, you've heard other sessions and presentations that have talked about some of these upstream factors that might be such as social determinants of health, education levels, socioeconomic status, racial or ethnic disparities. And when we start thinking about how to address some of these root causes, we need to keep in mind that education is one piece of this, and it's only one piece of this. That if we truly want to affect and make change related to fentanyl and opioid prevention and fentanyl and opioid use, we need to be willing to dive in and do this as a coordinated effort across a variety of different sectors where schools are key partners and are kind of central in that hub as well. To do this and to utilize the expertise that are in schools, we want to ensure that there are trained and licensed educators who are involved in implementation efforts. So this could be a variety of educators. One that comes to mind are your health educators who are trained and are designing classroom implementation on a daily basis, who are often also focused on teaching the skills necessary that young people need in order to affect that skill development. When we think about where these standards come from, or how do we know what we're teaching or why we're teaching, One key place to look is, what are your state level learning standards that show up for health education? They may also show up related to social and emotional development, but they might also show up in places like science or social studies when we're thinking about community norms and community values or understanding culture. So it might show up in a variety of different standards. At the heart of it is, though, is that we need to have state level standards. And so we want to make sure that when we review and or design and ensure implementation of, that there are standards available that include fentanyl and opioid prevention as a part of that educational experience. And we think about how those standards intersect with one another across content and topic areas. We need dedicated instructional time to support skill development and knowledge acquisition. It's not enough to say that we want young people to learn these skills and that there is some functional information that they will need to know related to this, but oftentimes that functional information, as Robert had said, that serves as a context for skill development. So if I'm talking about refusal skills or effective communication skills, what am I refusing or what am I communicating about? And how much information do young people need to know in order to apply these skills in their daily lives? But in order for that to happen, there needs to be dedicated instructional time. So this likely is courses that are built into students' schedules that every student has access to. And it is thoughtfully included across their grade level progression from starting in elementary school all the way up through high school. We know that development changes. We know that sophistication of decision-making processes change. We know that students' ability to use and transfer their learning outside of the classroom changes as young people get older. So the more opportunities that we can give our young people to practice, the more likely it is that they are then going to use and apply that new learning in real life novel settings because they are more familiar with it. The interesting thing about skill development is that the skills that they're learning actually cross over different topic areas. So when I learn the skill of refusal, I can use it whether I'm talking about alcohol, tobacco, other drug prevention. I can also use it in situations related to sex or sexuality. I can use it in situations where it might be exerting a boundary that might support my mental health. Whatever the case may be, the skill is the same. And so again, not only are they practicing that skill, but they're doing it in multiple settings and contexts that they can then apply to their own life. We want to ensure that whatever curricula we're using, it is aligned with best practices in prevention education. When we do that, we are more likely to ensure that young people are going to learn the skills and the knowledge they need to apply and use these in their real life settings. Now, this might look different in different districts depending on what the needs of the young people are in the community. And that's really key and really critical, because one of those key prevention strategies is to understand the population that you're working with. This might also mean that there are adaptations to purchase curriculum. When we're talking about adaptations, one of the things that we want to keep at the forefront of our mind are any modifications that might be made to it because of things such as the population or the amount of time that we have to educate our students. When we make those adaptations, and this goes into further detail in the document, but thinking about the types of modifications that to ensure that they do not fundamentally alter the learning experience, because of the curricula that and how they're designed, right? They're very intentionally designed. And there might be some things you can do from a modifications perspective, but there are other things such as completely taking out certain activities or completely changing the order that might actually make the that curriculum ineffective. Turn it over to Michael, who is going to talk about harm reduction.
Thank you, Holly. So we would love to believe that prevention would zero out use and abuse and the other problems that occur. But realistically, no matter what we do and how good we are at it, problems are going to occur. And the idea of the harm reduction approach is to minimize the impact, the medical and social impact that these problems occur after they occur. And so the idea of a harm reduction approach is to try to work beyond prevention or secondary prevention to increase the scope of coverage. One of the first steps is to make sure that you're integrating harm reduction throughout. And this, as you've heard, I think 2 or 3 times already, means having a comprehensive program that is developmentally appropriate across K through 12. And this includes things like policies, naloxone availability and training, peer support, stigma reduction, having safe spaces and open communication, and then integrating with community organizations and families and the people throughout the communities. So as far as policy goes, in the last review we did, 45 states made naloxone widely available, and about 25 of them specifically made them available to schools. At the minimum, policies should include a number of factors. One is it should specify when and how naloxone is available and describe who gets it and when and how it's made available to other people. It probably should also designate who's going to get it. Nurses, staff, teachers, students are all possible, and also designate training, which I'll get to next. It should also identify procedures for responding to the overdoses, what's going to happen if they occur in school, for example, calling 911, transportation to the ER, etc. And finally, there's the need for referrals. So naloxone is being made widely available in both intravenous and intranasal form. And I use the phrase intranasal, most of you probably know as Narcan. Narcan's a brand, and now there are other brands available. And so we talk about intranasal naloxone, which is the nasal spray version. And the widely disseminated assumption is that because it's a nasal spray, anybody can do it. And that turns out to be not such a good assumption. One follow-up study after a SAMHSA model training found that only 1/3 of EMS, police, fire, and lay citizens felt confident they could deal with overdose situations and administer intranasal or intravenous naloxone. So it's really not as simple as it appears to on the surface. We've done a review of over 100 training programs, and only 3 meet the standards or even come close to the standards that Holly and Robert have talked about as even being promising. And they are the Opioid Rapid Response System, getnaloxonenow.org, and DOPE, the Drug Overdose Prevention and Education Program. Those demonstrate some evidence or promising evidence in studies where there's a control group, pre-test and post-test, and reliable measurement. The final aspect of this is treatment, and having treatment referrals available at the school is exceptionally important and needs to be regularly updated because treatment programs change, they go in and out. You can click on some of these programs and not there anymore. And in addition, the programs need to have proven outcomes among the target group. And this includes the age of the kids and the culture of the kids. So what kind of treatment program are we looking for? The research suggests that a combination of meds and talk therapy is the best. And there are a variety of meds, methadone, I'm not going to pronounce this, buprenorphine, naloxone, along with things like contingency management and naloxone distribution issues. So those are the kinds of programs that are more comprehensive themselves that have proven to be effective. But treatment is not as easy as just saying to a kid, here's the program, because there's a lot of resistance to treatment. And even if you can get them into treatment, the compliance to treatment regimens for not just drug treatment, but for all treatments is low. And so there needs to be a system in place to ensure that the kids get the treatment and stay in the treatment and maintain. It's possible that you may require a mandate for treatment if the overdose occurs within the school setting. So I think we're back to you, Holly, for the next slide.
Sure are. When we think to now kind of bring all the pieces together here and to wrap this up in terms of recommendations, these are going to be highlighting, things that you've already heard that we really want to make sure are, written down or that you bring back to your settings. The first is that schools and communities can partner for a comprehensive approach to prevention and intervention. And in order to do that, we want to ensure that the right players are at the table. School leadership, teachers, parents and caregivers, community-based resources, potentially law enforcement, medical professionals, right? There are a lot of different folks who can come together to partner. And we need to partner if we truly want to affect prevention from a systemic base. It is also important that we implement evidence-based intervention programs, curriculums, and approaches that are known to decrease the likelihood of substance use. When we use these approaches, it's more likely to make a difference. Oftentimes, it's not uncommon to hear that folks will use things like scare tactics, or if we use a knowledge-based lecture, or we bring in speakers for a one-time presentation. And while these might seem on the surface to make a difference, they've been shown through research not to be effective and sometimes can cause more harm than they are helpful in preventing whatever it is we are trying to prevent. We also need to evaluate programs to determine effectiveness related to fentanyl and opioid use. As was mentioned earlier in the presentation, this is the best available information that we have to date. And further research, further work, and further specification needs to be done to ensure that this continues to remain true. Effective substance use prevention focuses on building youth skills rather than increasing awareness. And I know I touched on that, and I'm going to touch on it one more time, because sometimes, again, we default to wanting to make sure that young people know. The interesting thing is about how the brain processes information is that it learns by doing, and transfer of learning from one space to another space happens through repetition and context creation. So the more that I am able to take my learning, apply it to me, and then see how it fits into my world, the more I'm more likely to use it. And this is especially true with adolescents. Michael, we'll turn it back over to you.
Right. Okay, so a few more. And obviously, as I've said, the school should need to provide referrals for treatment and regular professional development for faculty and staff. It's one thing for the school nurse to know what to do, but it's really important that this be pervasive throughout the entire school culture and school system, because these overdoses occur any place and every place. And so we need a situation where everybody is ready to deal with it. So this regular professional development is essential. Schools need to begin developing policies and practices and regarding naloxone deployment. I was recently talking to the people from the Board of Education in West Virginia and was surprised to know that West Virginia's new law mandates training of students only and not faculty and staff. And so not only do the schools need to be at the table developing their own policy, but they might want to get on the horn and reach out to the legislature and talk about being at the table when these policies are being revised and expanded and changed or instituted in cases of states that don't have it. Because it seems pretty clear that this training and these resources need to be very widely disseminated. And finally, just like the prevention curriculum, the naloxone training needs to be evidence-based. A number of these programs have very minimal evidence supporting them. And you may feel good in implementing them, but they're much less likely to work than the ones that are evidence-based, just as Holly mentioned, for the prevention part. So we've reached a point early, and so we have lots and lots of time to engage your questions. And so let's hear them.
Thank you for breaking down the toolkit and bringing to life some of the concepts within it, but also putting things into perspective for us related to fentanyl and other substances that we've been dealing with up until this point. And I just want to clarify for the audience, a main message that has been generated in this particular resource and ask you to talk about it to any degree that makes sense to you. But what we're hearing is that we should be treating the integration of fentanyl as a specific substance, new and specific substance, and as we would any other new substance coming in to the lives of youth. We should be treating it through the same prevention lens for the use behavior. But then on top of that, with this nuance of overdose as an outcome, and sometimes an immediate outcome, even a first-time use, that there are other additional strategies, such as naloxone, that can be integrated into the existing infrastructure for the use behavior. I want to clarify that that is what we're hearing for our audience.
Yeah, I would say that opioid and fentanyl prevention, the skills that youth need to learn and develop and practice over time are no different than they would be for tobacco or alcohol use prevention. I do think there needs to be some primary prevention education that relates to the use of testing strips that let's say teenagers could use as a harm reduction approach, as well as what Michael had said is some training on overdose recognition and the use of naloxone. That being said, the evidence base regarding specific school-based prevention programs aimed at opioid and fentanyl overdose is just not there yet. And I'm not very optimistic that it will be there yet, because I don't think schools would be doing service to youth if they just addressed opioid and fentanyl overdose. That would be the same thing as if school said, well, we're only going to teach addition throughout the year for our math course. There are other skills that can be used. And as Holly had pointed out, those skills can carry over to other risk behaviors as well. So these are not in isolation. Oftentimes when we look at the research regarding effective alcohol, tobacco, and the drug prevention programs, we see improved academic outcomes like attendance, improved positive behavior in the school. They turn their homework in on time, those types of things. Because one of the things that the former Secretary of Health, Jocelyn Alder, said is an unhealthy kid can't learn, and a kid that's not learning can't be healthy. Health and academics go hand in hand.
Well, let me piggyback on that because not every evidence-based program has been evaluated for eventual opioid use, but 2 of them have life skills training in all-stars and show later effects on opioid use, even though opioids are not directly addressed in either of those curriculums. So reinforces kind of what you've heard about the basics of prevention and how it will generalize.
We had a question, the very first question that came in, that I'm going to rephrase just a little bit. People define education differently, depending upon if they exist in the education sector, if they exist in the prevention science sector, if they exist in government. Everyone can potentially have a slightly different read, maybe it's better said, of the expectations for that education and the outcomes that ultimately will result. So and this comes up a lot with TA, there is some confusion related to if we, in these standard prevention curricula that have an evidence base supporting and demonstrating the effectiveness of preventing or reducing use in youth, can you please speak to, are we teaching them to use if we are educating them through these universal prevention curriculums? Can you speak to that one question first? Because that comes up time and time again, and I think that's based on previous programs that may have shown potential harm that have resulted from those studies. Can you speak to that specific question. Are we teaching them to use if we are teaching them about the substances?
So Laura, what I hear you asking is, if we do something in the schools to prevent drug use, would that actually increase the likelihood that they would use alcohol, tobacco, and other drugs?
If we are educating them on substances.
Right.
Yeah.
Well, I'll say two things about that. One, to my knowledge, having worked in this field, both as implementing programs in schools, but also as researching the effectiveness of these, I've never seen an evidence-based intervention increase the likelihood that kids would either begin using alcohol, tobacco, or the drugs, or increase the frequency of drug use. And I get this question a lot as it relates to other risk behaviors that we as a society want to prevent. And one of my responses are, well, we teach kids at a very early age that they need to do the dishes and they need to clean their room, but we as parents know that they don't do that all the time, right? But what I will say, there is some evidence out there where some of these approaches that Holly was addressing, like scare tactics, dramatization, kind of information only approaches, have demonstrated negative effects. For example, I was evaluating a program in Southern California that was completely knowledge-based, where law enforcement officers had a billboard, not a billboard, but like a 3-try kind of placard, and they actually had actual drugs up on that, and they used that to show kids, well, this is what methamphetamine looks like, this is what marijuana looks like. And when we compared kids who had gone through that 4-day educational session to kids who didn't go through it, we found no changes in the likelihood that kids would use alcohol, tobacco, or the drugs. But we did find is that the kids that went through that program compared to the kids that didn't go through that program could identify quality methamphetamine versus low-grade methamphetamine. They could identify really good marijuana with high THC versus homegrown marijuana. So essentially the only effect that program had was making better drug consumers. And so we want to be careful that when we talk about school-based drug prevention programs, that there are some approaches that have the likelihood, I don't think it's a huge probability, but the likelihood that it could have negative effects. Holly, what do you think?
Yeah, and I think that, we sometimes hear the argument that if we don't want to bring it up too early because we're going to inform young people about it. What in talking with young people, and especially with the advent of social media, and not even just social media, but media in general, is that our young people are consuming a lot of information. Some of it is true and some of it is not true, all around them, whether it's from peers, adults, right, the internet, like all sorts of different sources. And to not talk about it doesn't mean that young people won't be exposed, and to not give them the skills to address it doesn't mean that, right, we can just push it off until later. What it really means is that we're leaving them to their own devices to figure it out. And another piece is that when we think about effective prevention education, we don't want to start prevention education when we see the numbers start to tick up, right? If we're looking at risk behavior surveys or different things like that, if we see in 9th grade, certain behavior is starting to tick up, we don't want to wait until 9th grade to talk about it. In fact, we want to be in earlier middle school so that we can prevent the onset from that happening to begin with. So I can completely appreciate it. And as a parent, sometimes you grapple with these ideas of, should I talk to my kids about this? Should I not talk to my kids about this? But I think that at the end of the day, that we do want to, and it's beyond even empowerment of our young people, we want to help them to develop both the self-efficacy and their belief in their ability to kind of navigate these situations, and the agency that they have the ability within themselves to really navigate their course. And if they can't do it themselves, who are my adults? Who are those people in my life that I can seek out to support me?
Thank you. So one final time, we're going to say this in a slightly different way, but we've had enough questions come in about it that I just want to say it one more time and hear how you would address it. So one viewer is saying, I'm having a difficult time with you suggesting that fentanyl poisoning is in any way similar to other substances. Many are still unaware of the dangers of fentanyl. Speak to that. One final time, how should she or he think through fentanyl poisoning specifically and the dangers of fentanyl? It's a very common phrase. When we hear fentanyl education, that's what people are educating on, the dangers of fentanyl.
Well, I think you need to separate two things. I mean, yes, dying from a fentanyl overdose is different from smoking marijuana, but the prevention of fentanyl use and prevention of marijuana is what we've been talking about. And that there are similar principles involved in the prevention of both of those situations. Robert, is that what you, or Holly? I know it's one of you was jumping in.
Yeah, I would just add, I think that comes from the supposition that, and it's an erroneous supposition about just behavior change, is that if people just had the knowledge or they were aware, that they would act in a way that would, decrease their risk or decrease the likelihood that they would get sick or die. And I would ask the participants today at the summit to think about, well, do you know that speeding on the freeway can lead to getting in a traffic collision, include killing yourself or killing somebody else? And most people would say, well, yeah, I know speeding is not a good thing to do when I'm driving my car. And I would ask them, well, do you see reminders of how fast you should drive? And they'll say, yeah, every couple of miles, there's speed limit warnings. And I'll say, are you aware of, a perceived risk of consequences? Like when you see a police officer, do you slow down? They'd say, yeah. Then I would ask them this, in the last 30 days, how often have you driven over the speed limit? And most people, if they were telling the truth, would say, yeah. So our knowledge and awareness doesn't necessarily coincide with our behavior. And that is particularly true with adolescents because of the way that the adolescent brain works. The part of our brains that deal with perceptions of risk and susceptibility and severity, the prefrontal cortex, is severely immature up until about the age of 25. So even if you did go to youth and teenagers and you said, listen, there's this drug that could be found in 1 in 7 tablets, just any type of opioid, and it's called fentanyl. That approach is not going to work because the teenagers' brains are not wired that way. But if you go to them and you say, hey, listen, I'm going to teach you how to communicate assertively. So if you don't want to do something because that doesn't coincide with your future plans and goals, and then we're going to practice using that skill until you can use it in your everyday life, that skill will prevent them from taking that pill in the first place.
Sounds like
Yeah.
a both and approach. So honoring the behavior piece of prevention, and to Holly's point earlier, for those school districts or communities where there is an identified higher risk, and even for those school systems that have determined we would like to universally train our middle or high school students with basic Narcan training to address that potential outcome of the use, that both of those are viable and important.
Yeah, and if I could jump in here, that, I think one of the really cool things that happens when we involve young people in their education in a way that makes it about them and thinking about how their actions and even the world around them, so it's more than just their actions, have an effect on their, overall health and well-being. We really put them at the center. And as Robert was talking about, the adolescent brain is wired that way. It likes to be at the center. It has to think that way, and it's evolved that way for a really long time. In fact, hasn't really changed, a whole heck of a lot. But when we help young people to think about, why am I taking anything into my body? Yes, the reality is that certain things could be far more dangerous, and we need to address that and identify that, so that we are getting that naloxone training, we're understanding that. Same reason we wear a seatbelt. Not that we're going to get into a collision every single time we get in the car, But for the time that it happens, we want to make sure we're prepared. Similarly, on the substance use prevention side of things, and even starting as early as our youngest students in elementary school, helping them to think about, when can I take this by myself, or when do I need to talk to an adult before I, take a pill or use first aid cream or whatever the case may be. We're not talking about bringing in fentanyl right into kindergarten and educating specifically about that. But even those conversations about, when is this something I can do myself, or when do I need help from an adult, is building that groundwork for future substance use and then fentanyl and opioid prevention efforts.
Thank you. We are going to transition to a different type of question that also comes in a lot through technical assistance. And I just want to thank you for honoring the prevention science and helping us stay true to that, while also acknowledging this nuance of fentanyl and helping us think through how to best integrate that into the schools. But here's the question. And several of you have entered many more. So here we go. All right. I know we've said that a one-time presentation or a guest speaker is not recommended. If a school still chooses to go this route, do you have any suggestions for ways to make that intervention effective?
So the intervention in and of itself, by itself, will never be effective, right? So if you are choosing to bring in guest speakers, and they're, it's not to say that bringing in other voices can't be useful. However, what you want to make sure is, before any guest speaker ever comes in or any assemblies are had, that we're thinking about what is being taught, say in the health education space. We're coordinating with those teachers. We're building in learning experiences that might come before or after that presentation. We're thinking about, if we're doing parent or caregiver presentations, how that is connected with, maybe there's something that comes out of the classroom experience that then students are able to go home and have a conversation with their family or caregivers. It becomes this coordinated effort. And so that speaker in and of themselves isn't, this is the education and now we're done. It becomes part of the process that requires the integration of the teachers. Maybe it's you bringing in the school counselors or social workers into the conversation too, because once we bring these things up, that might also tip students to want to seek mental health care or support in some way. So being really thoughtful and not just bringing them in, but making it part of a larger process.
Yeah, and I'll just add something to what Holly says. There's no evidence that bringing in a guest speaker, like a former addict or a physician or a nurse, is going to either reduce the likelihood that youth will use drugs or reduce the frequency of drug use. There's over 25 years of research that shows that's a completely ineffective approach. And what I might add is two other things. One, when schools do that, they're taking up time and space for where a more effective approach could come in. And then lastly, I would really encourage those schools that want to get to outcomes to work with their school board and their district leaders to develop district policy that requires the use of evidence-based interventions in schools, much like we do with mathematics, language arts, and social studies.
Thank you, Dr. Lachos.
Yeah, just to build off of what Ben said. So for example, the one time it was really popular to have Red Ribbon Day. And as Robert said, absolutely no evidence that that by itself is going to do anything. But if that was integrated into a program of normative influence to demonstrate to people that most of their peers are not using drugs and don't want to use drugs, then it could become part of a larger overall program. And the other comment I wanted to make is that, and it's something I hear a lot. There was a speaker at my school and it scared me, and I don't use drugs. We're talking about programs that are likely to work overall and on a large group of people. And I don't think anyone is looking for a program. If you're looking for a program that's going to work on one particular person, that's called therapy or peer support. And that's not what our report is about.
Thank you. And Dr. Lachos, of course, I have you in the back of my head because you've conducted some technical assistance with us in communities. And your famous question that we have adopted to some degree is, what is the opportunity cost? If you are spending an hour, 2 hours, what are you not able to do because that time is being appropriated to the speaker? And so I thank you for both Holly and Robert for talking us through, if you are going to do it, how to consider making it, setting it up for success in ways that could attach to some of these core components that we do know have been demonstrated to work. So thank you for that. Another thing we also say through ADAPT is, a lot of communities, for whatever reason, they are invested or want to try something. They want to try an intervention. They're aware of the evidence, maybe either not supporting it or unknown. And we always encourage, that's okay. That's okay. Just whatever you do, evaluate it. That's one of our main messages. Make sure it's getting you to those outcomes that Dr. Lachos was suggesting earlier. We're going to end with this question because, this is ADAPT is in the business for better or worse. The types of TA questions we get are hard. We don't always have the answers to them, especially in the ever-evolving landscape of substances. We have a question specifically related to naloxone training. And when would you start? Is there a minimum age? Are there any other requirements? Would you do it inside the school or maybe outside of the school setting, more in the community? And all of the above. How would you think through, and this comes up a lot, when do I start? How do I think through that minimum age that is going to help me then determine when I invest the time and resources into it?
That's kind of a difficult question because we don't have a lot of research on that. The naloxone training is just emerging. So clearly, if you're talking about teachers and staff, they can all be trained. They can all be trained right now. And a number of the programs available are super long and they don't need to be. They can be much more focused and effective than that. And the three I mentioned all do that. It's hard to say developmentally when a kid is ready to do that. It would appear that certainly the later grades in high school are able to be trained. And I think I would turn it over to some of the more developmental people to say, how far down we could go, because we really don't have a lot of evidence on that.
Thank you. And I think that's a very transparent answer. We are all still figuring it out to some degree, and we are considering various risk factors that are in our own communities to help inform that decision. So thank you for being honest about that. It is still an emerging evidence base. I will say, you'll hear me announce at the end of the summit that we do have an upcoming webinar with Dr. Nate Roos here I believe it's in the November-December timeframe, and he'll be talking with us about developmentally appropriate strategies and how to tailor interventions to various developmental levels and just how to think through developmental theory. And that could potentially be helpful as a starting point, and some additional considerations for making those decisions. All right. This was not the easiest of panels, right, guys? I know that we've thrown some tough questions at you, and I appreciate that you've brought forward just a very honest and transparent look at the best available evidence at this time. As I mentioned earlier, the resources available to you as a starting point for thinking through it yourselves. And at this time, we are going to venture off for a break. Panelists, thank you for joining us, and we will see you all back at 3:30 p.m. Eastern for the final panel on implementing a social norms media campaign in a middle school. We did this across 10 middle schools across the United States, multi-HIDA project. We are so excited to share with you those outcomes. We'll see you back.